stop?
No, fine.
Okay. Modified technique of OPD FG that I call as OT FG. Now, in this video, using a 26 gauge bent needle through the sclerotomy site in the horizontal meridian, and I am using fluid air exchange. FG port is used to inoculate the air with pressure inside the vitreous cavity, which is on the nasal side. You can see the 26 gauge needle, and on the temporal side, the needle is open, and 30 to 40 pressure is set for fluid air exchange, and now you can see the blood is drained from the temporal side. So pressure is well maintained, patient is in lying down position. You can utilize microscope light and the magnification, and moreover the advantage at the end, you can inject anti-VEGF intravitreally. See, the magnification and light very well used, and patient is little bit turned on the temporal side, so that the drainage will be more. Now this is the fluid air exchange tube which is attached to the FG port on the console. So thank you very much for your patient listening. This is the modified OPD FG that I call as OT FG. The advantage is that it can be done in lying down position as against OPD FG which is done in sitting posture. It is cumbersome for the patient as well as doctor, and you have to perform with the help of indirect ophthalmoscope, and IOP is fluctuating. You cannot monitor it, and also you cannot inject anti-VEGF injection in OPD-FG cases. So it has a good modification in a vitrectomized recurrent hemorrhage, vitreous hemorrhage cases in diabetic, proliferative diabetic retinopathy cases. Thank you very much for your patient listening.
So though we call it as a OPD FGE, I don't think many surgeons will do it actually in the OPD. So most of us will prefer to do all these things in the OT and in sterile conditions, and patients have been draped. So you can use various techniques to remove the liquefied blood, but more important is to examine the retina and find why it is bleeding. So doing a simple FGE might solve the problem temporarily, but you have to address the issue why it is bleeding. So that is why after doing the FG, you have to examine the retina, and if more additional laser, membranes, some more peeling is required, those things have to be addressed. So this is the first step to just clear the media, and you have to address the main issue why it is bleeding. So this is the first step that you do to clear the media, but the equally important thing is to address why it is bleeding. So the rebleeding can be due to inadequate PRP, unrelieved traction, or persistent second membrane. So these are the some of the common things, causes for the recurrent bleed. So it's a good technique, non-invasive technique. Instead of making traditional ports and using trocar cannula, this is a good technique.
Post-operatively, immediately post-operatively, we have to wait for some time. But many times hemorrhage don't come down, then we have to go for this. So in such cases, we also need anti-VEGF. So in OPD-FG, that is IOP is fluctuating, unsterile condition, patient is also not happy. We are also, there's a tedious procedure. So I found this as a good modification. Patient is also comfortable, we are also comfortable, and the pressure is very, very maintained. And anti-VEGF injection also you can give simultaneously, means concurrently.
Yes, any...
Yeah, that we have to address the cause of the hemorrhage subsequently. If there is yeah, we have to do AIOC because endo laser is not possible. You have to go 3 port then again. You have to go through sonography and all those B scan you have to do prior to this, and then you have to find out the cause of that, and then accordingly you can plan the treatment. This is just OPD. Instead of OPD FG, I have this replaced with this OT FG.